So I was just in Austin at the LACNETS conference, and LACNETS is all of the doctors in North America who are working on neuroendocrine cancer, and it was quite amazing. I think it's the first year where there was literally a triple announcement first thing in the morning, which was all fantastic news. And one of those announcements was about carcinoid syndrome, and for patients with carcinoid syndrome, that the results of a trial that's been happening put on by Lexicon Pharmaceuticals. So we're extremely fortunate that coming from the East Coast to have Pablo LaPuerta, the Chief Medical Officer for Lexicon, here to talk about, see if I can get the drug right, Telestar Etiprate. You could correct me if I'm wrong on this.
Got it right.
Please welcome Pablo LaPuerta.
Well, thank you very much. It's really a pleasure to be here. I love the Los Angeles area. I used to live here. In the mid-90s, I was a professor at the University of Southern California in internal medicine. And it was 1996 that I moved to work in the pharmaceutical industry in the development of new medications. So this is my 20th year in the industry doing this. And this project, Telestar Etiprate, for me, it has represented 5 years. For others, it's represented many more of effort. And it's an honor for me to prepare a summary of these results and to share them with you. These are the slides that were presented at the North American Neuroendocrine Tumor Society. An important disclosure, Telestar Etiprate is an investigational agent. It still has it has very positive results that were shared with the scientific community recently at the North American Neuroendocrine Tumor Society, but evaluation of its safety and efficacy is still ongoing. There are other trials that will be contributing to the whole package that the Food and Drug Administration needs to review in making its decisions on whether or not it should be approved, and if approved, what sort of advice to give to physicians and patients on its safe and effective use. The principal investigator for Telestar is Matt Kulke, and I'm giving this talk on behalf of the steering committee. Matt Kulke at the Dana-Farber Cancer Research Center and Dieter Horst at Bad Berka in Germany were two of the most prominent physicians who recruited a lot of patients, who really put a lot of effort into this, and there were many more. As you may know, carcinoid syndrome is a condition caused by the release of serotonin into the peripheral circulation by carcinoid tumors. The tumors release serotonin and some other vasoactive substances, and the results are flushing, diarrhea, abdominal pain, fibrosis, and even cardiovascular heart disease. Now, it was about 50 years ago that a treatment for carcinoid syndrome was developed, a product that came from Pfizer, actually. And it inhibited the production of serotonin by the tumor, but it had a problem that it was not tolerated by patients. As a matter of fact, of about 8 or so patients that were described in the New England Journal of Medicine, I think only 1 could really take it long term. And the issue there in trying to stop the synthesis of serotonin was that this older product, 50 years ago, was crossing the blood-brain barrier. People had trouble with depression, severe fatigue, really had trouble taking the medication. The idea behind Telestar Etiprate was to stop the production of serotonin by the tumor without crossing the blood-brain barrier. It was a simple proposition. There's an enzyme, tryptophan hydroxylase, that is the rate-limiting enzyme for the production of serotonin by the tumor. Telestar Etiprate is designed to block that. In 2 early-stage studies of Telestar Etiprate, there were some signs of efficacy, and the safety seemed good. It seemed to be well tolerated, and patients were able to take it long term. There are some patients that have taken it for almost 5 years now from these early phase 2 studies. That was a rationale for us to advance into phase 3 clinical development. And the FDA responded to these early data, granting us fast-track status and orphan drug designation. What we presented in Austin was pivotal results of our phase 3 trial, Telestar. Telestar was a study designed with 3 different treatment arms. Patients who were on somatostatin analogs with well-differentiated neuroendocrine tumors and at least 4 bowel movements per day were randomized to either placebo, telotrestat etoprate 250 milligrams, or telotrestat etoprate 500 milligrams. This treatment period was 12 weeks. I'll be sharing with you the results over 12 weeks of double-blind therapy. But after 12 weeks, we provided access to all patients for telotrestat etoprate, and that's part of the safety evaluation that's ongoing. All patients had to be on a somatostatin analog at enrollment and to continue that somatostatin analog therapy throughout the 12 weeks that we were comparing telotrestat etoprate to placebo. So telotrestat really is meant to be an addition to somatostatin analog therapy, which we recognize as the standard of care for this area. Patients were allowed to use any antidiarrheal that they felt was beneficial to them. Physicians were allowed to prescribe that. Some physicians even used periactin. I don't know if you're familiar with that. But anything else was allowed, including short-acting rescue octreotide. Key inclusion criteria were having a neuroendocrine tumor that was metastatic. It had to be well differentiated. You had to have a diagnosis of carcinoid syndrome by your physician. There had to be at least 4 bowel movements per day. And you had to be on the somatostatin analog therapy, and it had to be at an appropriate dose. You'll see many patients were actually on doses higher than those in the FDA-approved label for somatostatin analogs. People were excluded if they had more than 12 bowel movements a day and were felt to be clinically unstable because of the severity of their condition, or if they had infections that could explain the diarrhea that they were experiencing, or if they had just recently received anti-tumor therapy. Many patients, probably the majority of them, had received some anti-tumor therapy early on in their history, but not just in the 4 weeks prior to screening. And some people, because of surgery, would have diarrhea from what's called short bowel syndrome. That was an exclusion criterion. The primary endpoint was a reduction in bowel movement frequency. The idea was that telotrestat etoprate would block the production of serotonin by the tumor, and that would control the diarrhea. We averaged bowel movement frequency every day over 12 weeks. So patients had electronic diaries, and every day they put into the diary exactly how many bowel movements they experienced. So every patient provided really 84 assessments that went into an average to compare telotrestat etoprate to placebo. We pre-specified statistical criteria for claiming success in this study, and we adjusted for baseline serotonin production indicated by urinary 5-HIA, our marker of serotonin synthesis. The characteristics of the patients in the study were pretty similar between placebo, telotrestat etoprate 250 milligrams, and telotrestat etoprate 500 milligrams. And like other studies in carcinoid syndrome, you see a population that was in the early 60s, about half male, half female, and between 5 and 6 bowel movements a day at baseline. About 70% or so of the patients were on octreotide, many of them above the highest recommended dose by the Food and Drug Administration. And urinary 5-HIA, that marker of serotonin production, was elevated in most patients. With levels, you see 80 to 90 milligrams per 24 hours. The upper limit of normal in most labs is around 8 milligrams. So these are about 10 times higher on average. Here are the main results for the primary endpoint of Telestar. The results were highly statistically significant. The 250 milligram dose reduced bowel movement frequency more than placebo with a p-value less than 0.001. The 500 milligram dose also, the same type of statistical significance, p less than 0.001. And why? You see a clear differentiation between placebo, 250 milligrams, and 500 milligrams, starting as early as week 3 and then growing over time, until finally at about week 12, what you see is that the 2 treatments were reducing bowel movement frequency about 2 bowel movements per day. You see that a little bit more precisely here in this graph. The bowel movement frequency on placebo had a little bit of a change from 5.2 to 4.3, right? And that's a reduction of about 17% from that baseline value to the week 12 value. With telotrestat etiprate, you had reductions of 29 and 35%, the week 12 value being that much lower than the baseline value. Now, is this clinically meaningful for patients to reduce bowel movement frequency by about 35%? One analysis that we did, we pre-specified with the FDA. The FDA asked us, what is your definition of clinically meaningful change for patients? Well, clinically meaningful change, depends a lot and is something individual for every patient. But we suggested a bar that if someone had a 30% reduction in bowel movement frequency, that was clinically meaningful to them. In particular, if it was sustained for at least 50% of the days of the 12-week period. And according to these criteria, which we set out in advance, the response rate on placebo was 20%, but it was more than double that on telotrestat etiprate. And that difference in response rates was highly statistically significantly different, favoring telotrestat etiprate over placebo. I'll show you a bit later some things that we learned about the patient voice in this study, speaking more to clinically meaningful change. The reductions in serotonin synthesis were very important here, and were much more with telotrestat etiprate, 250 and 500 milligrams, than with placebo. With placebo, there was a small increase in serotonin synthesis. I don't think this was statistically significant, but it went up by 11 milligrams from a baseline of 80 to 90. With telotrestat etiprate, 250 and 500 milligrams, you see reductions on the order of 40 and 60 milligrams per day from baselines of 80 to 90. So these are reductions, if you think about it, on a ballpark of 50 to 66% or more with telotrestat etiprate. And it's important when you think about the role that serotonin has in the progression of carcinoid syndrome and its long-term consequences. Another way to look at these data in terms of the ability to inhibit serotonin synthesis is to look at what's called a waterfall plot. Here, every single patient who had a value that was non-zero at baseline and had an assessment at week 12 is portrayed. On the left, you see the 250 milligram group of telotrestat etiprate in blue and placebo in gray. On the right, you see the 500 milligram group of telotrestat etiprate in green and placebo in gray. And so you see that the majority of increases, which are here to the far left of the two graphs, are on placebo. And the majority of the decreases are on telotrestat etiprate. In particular, if you look at the 500 milligram graph, nobody had any increase in urinary 5-HIA in this study. So that was really quite a separation between the two treatment groups. There were additional secondary endpoints. Abdominal pain and flushing were secondary endpoints in this study. Now, there were reductions in abdominal pain and reductions in flushing for both 250 milligrams and 500 milligram doses, and they were both greater than placebo. However, they did not reach statistical significance. And probably one of the reasons is that this was a population whose main issue was controlling bowel movement frequency. Only 40% of patients had at least 2 episodes of flushing per day, so that you really could get a lot of rigorous assessment of flushing. And the same thing applied for abdominal pain. Again, it was only 39% of patients who had abdominal pain of at least 3 on a scale of 0 to 10 at baseline. Now, safety is very important, and during the 12 weeks of Telestar, the safety was very favorable. If you look at the incidence of treatment-emergent adverse events, which is really any sort of thing, including colds and flus, was similar between the 3 treatment groups. If you look at serious related adverse events that might lead to, say, a hospitalization, it was also similar among treatment groups. And if you look at serious adverse events that led to discontinuation from the study, it was actually a little bit more common on placebo than on telotrestat etiprate. However, there were some more adverse events that were considered related by the investigator. The investigators, we spoke to them about the potential for telotrestat etiprate to cause nausea. And there was a fair amount of nausea, in particular on the 500 milligram group. And I'll show you a little bit more information about that in a minute. And that's why you see on the 500 milligram group, there were a lot of treatment-related adverse events compared to the 250. The 250 was very well tolerated. And if you look at some adverse events of interest, which were nausea and its severity, you see that the 250 milligram group looks like placebo. If you look at nausea and see how severe it might be, well, the 250 milligram group looks like the placebo, and there were no severe cases on the 500 milligram. If you look at nausea and whether it led patients to discontinue from the study, nobody discontinued. There were also adverse events that were reported as depression, and we wanted to follow this closely, so much so that at every visit we had a screening question for any signs or evidence of depression. And physicians reported adverse events using the term depression or depressed mood in several patients. The 250 milligram group, again, looked like placebo in terms of the incidence of what was called depression or depressed mood. The telotrestat etiprate 500 milligram group had a few more events than placebo. However, if you look at severe depression or depressed mood, the number was 0 during the 12 weeks of Telestar. If you look at someone wanting to discontinue because of depression or depressed mood, the number, again, was 0. And when we go into questions and answers, I could provide a little bit more of a perspective on some of those adverse events, if you like. So the Telestar Steering Committee concluded that telotrestat etiprate significantly reduced bowel movement frequency in patients with carcinoid syndrome taking somatostatin analogs. The differences were clinically meaningful, in particular if you look at this responder analysis that we prepared, where there was more than twice the response rate on treatment than placebo. The safety profile was favorable, and telotrestat etiprate was well tolerated in this study. It's nice to see that there was significant reduction in urinary 5-HIA, our marker of serotonin synthesis, because that speaks to the mechanism of action, and it also shows the role of serotonin in carcinoid syndrome. So we believe that telotrestat etiprate is a potential promising new treatment for patients with carcinoid syndrome. Now let me share with you some work that we did on the patient voice, trying to get patient perspectives on Telestar. We did something that was very different and I felt was innovative. We interviewed patients in an open-ended way and asked them about their experiences during the trial. And one of the reasons that we did this is because there's a lot of value in qualitative research in clinical trials. And the use of this research is just really growing by leaps and bounds in clinical studies. If you do this well, you make it rigorous, and you work with experts, you can explain your trial findings, make sure that your intervention is meeting the need of the patient, support the validity of your study, and ensure that you've used the right measures to reflect on the right outcomes. This is a bit different when we interviewed patients and we did it with an expert in really an open-ended fashion. It's different than your standard assessment where you check a box on a quality of life form. And it actually has a lot of advantages. You can capture the impact of symptoms on the daily life of the patient. You identify the priorities of the patient. You can ask, of all these symptoms that change, which was the most important to you? Was it clinically meaningful to you, and why? And that speaks to the clinical relevance of the work that you've done. And standardized questionnaires, you have some standard rating scales, and so you can have an experience where they've been used in many different studies, and that's very helpful. But they have the limitation that you're giving equal weight to maybe 50 different questions, when the most important one could be something very special to a patient. And you can only deduce clinically meaningful change from aggregate data, trying to look at numbers. And we have to find a way to understand the patient is not a number. And hopefully we've done that to some extent with these interviews. Our objectives were to learn how baseline symptoms affected patient lives, but also during Telestar to understand which symptoms changed the most and whether or not the patients were satisfied with their treatment on telotrestat etiprate. The way we did this was inviting clinical sites in 5 countries, all the countries that spoke English or German, in the Telestar program. Telestar program had many different countries in Europe and North America and also included Australia. We pre-specified an interview procedure with a formal protocol that was reviewed by ethics committees and that was developed with an expert in patient assessments. Most importantly, we got consent from subjects before they were randomized. This was not about highlighting 1 or 2 good responders. It was getting a comprehensive and unbiased assessment of everybody so that before you were randomized, you made your commitment that you would talk about your clinical trial experiences to the expert interviewing you. The interviews were conducted by phone, and we did them as soon as patients exited the 12 weeks of Telestar. And we made sure that the patients, the physicians, the clinical sites, and the interviewers were all blinded, so nobody knew exactly whether or not they had been on an active drug. The interview was done in 2 phases. The first phase was really about your baseline experience with carcinoid syndrome, how it was affecting your life, what was most important to try to control. And the second phase was about whether or not you experienced benefit from the clinical trial and whether that benefit was important to you. We only had 3 questions where we had specific numbers. These were the 3. The first one was about bowel movement frequency. Was it a lot better, a little bit better, not better, a bit worse? Similar question on stool consistency. And then the third question was the most important to us, integrating the overall experiences. How satisfied were you with the ability of the study drug to help control your symptoms of carcinoid syndrome? And the best result here is very satisfied. The way this was analyzed, since a lot of this was informal and letting the patient tell you what the most important symptoms were, is called constant comparative analysis. People give different terms in describing their experiences. Someone talks about the stomach, someone talks about the abdomen, someone talks about the belly, someone talks about bellyache, someone talks about stomach pain. Right? We had experienced interviewers who were used to this and were able to categorize the types of answers that patients were describing to them in a formal way. It's a method that's supporting the accurate reflection of participant views. And all of this was analyzed, categorized, and presented in a blinded fashion. So 35 patients were recruited across 16 clinical sites. The Telestar study overall had 135 patients. So this was more than a quarter of all the patients in Telestar. And they were conducted over the same time frame as recruitment into Telestar. And the patients in this interview sub-study were very similar to the patients overall. Similar age, similar proportion that were female, similar proportion that were white, similar weight. It was a thin population. But most importantly, similar bowel movement frequency, almost 6 bowel movements per day when they first started the study. The baseline symptoms, the most prominent symptom was diarrhea. Diarrhea described either as too frequent bowel movements or with the word diarrhea itself, or characterization of the stool. So it really predominated in this population, and it turned out to be very important to them. Now, other important symptoms that should not be discounted. Low energy was very common, so that was 63% of patients, and flushing was present in 80% of patients. But which symptom was most important? It was diarrhea. Patients talked about having 10 bowel movements a day, which was not acceptable, feeling tied to the bathroom, limited in their social and physical activity, not being able to control their situation, describing when all I had to do was try to move or walk, I had to go running to the toilet. There was one patient who gave an example of how this affected his life. He said it was a man who was invited to be the best man at his son's wedding, and he said he had to say no. He could not guarantee his son that he could stand for the duration of the ceremony, right? So this is really an important symptom to patients that we were trying to improve. When rating the most important symptoms to treat, diarrhea was number one. That term too frequent bowel movements also came up and was very important. Flushing was less important, and urgency was considered important. But it was mostly about controlling diarrhea for patients who enrolled in Telestar. How did it impact their lives? Well, it limited their social function, their physical function. It limited their ability to enjoy life, their emotional well-being. A lot of patients felt it was decreasing their energy and affecting their occupations, their ability to work both in and outside the home. It interfered with travel, not being able to take long airplane flights, for example, or long car rides, and sleep, having to wake up at night with bowel movement. So now we're going to phase 2. During this Telestar study, what happened? Did your symptoms improve? And if so, were the improvements meaningful to you? 88% of patients said something improved, bowel movement frequency. 80% said stool consistency improved. 58% said urgency improved. Now this is all patients, and they didn't know if they were on treatment, whether they were on treatment or placebo. I'll share with you a little bit later the results for one treatment group versus another. 50% said their energy improved. That was encouraging to see. Was the improvement clinically meaningful? Well, 21 patients described an improvement in bowel movement frequency. 20 of them, so that's 95%, 20 of them said it was clinically meaningful to them. Why was it clinically meaningful? The most common answer was that it was helping patients enjoy life, leave the house, and participate in social and other activities. There was a common theme was a sense of freedom. And this is a typical quote, "I definitely feel like I'm not a prisoner in my house." That theme came out several times. The biggest change is not having to run to the toilet. You can't live going 20 times a day. I don't think the patient was going 20 times a day, but I think we understand the experience and the change. The most important thing here, qualitatively, I was able to go out more often. So we feel that this was important to patients. They told us so. Patients were also asked, you know, if you're describing this amount of bowel movement frequency, what sort of reduction would you need to have something that really mattered to you clinically? And most patients said that changes of 30% or more would be clinically meaningful to them. That encouraged us because even, you know, not looking at the breakdowns between treatment or placebo, it encouraged us that we had the right endpoints and the right sort of analysis when we look at durable response to treatment. Still, the treatment arms are pooled here. Here's satisfaction. Satisfaction and how it compared to the reductions we saw in electronic diaries. That first part you saw, where people had reductions of almost 2 bowel movements a day on telotrestat etiprate. Well, patients who reported low satisfaction, we went back and looked at their electronic diaries. Their bowel movement frequency reductions from baseline to week 12 were less than 10%. Patients who were somewhat satisfied, we looked back in their diaries, and their reductions were really only around 10 to 15%. But the very satisfied patients had bowel movement reductions of 40%. So patients knew what was going on. And what they were telling you really went very well with the bowel movement frequency reductions that I showed in the first part about the Telestar overall results. Now, I showed that there were 3 questions with numbers, and so I'm sharing with you the satisfaction question and how it related to another question, is whether or not your bowel movement frequency was a little bit better, much better, or a great deal better. And if you look at patients with low satisfaction, the most common response is they had no improvement in bowel movement frequency. If you look at people who are just somewhat satisfied, the most common response is that they were a little bit better in bowel movement frequency. But you look at people who are very satisfied, the most common response is that they were a great deal better in bowel movement frequency. So that shows the consistency of the data as we spoke to patients. Let me share with you how this looked in terms of placebo or telotrestat etiprate. You saw 12 people who were very satisfied on the prior slide. They had a 40% reduction in bowel movement frequency. Those patients, all 12 of them, were on telotrestat etiprate. Overall, 50% of patients in the interview study who were on telotrestat etiprate reported being very satisfied with the ability of telotrestat etiprate to control their symptoms versus 0 on placebo. There were other patients on telotrestat etiprate who gave a rating of somewhat satisfied. If you add those two up, those two categories, somewhat satisfied and very satisfied, you see that 2/3 of telotrestat etiprate patients reported satisfaction compared to only 1/3 of placebo patients. The responses on telotrestat etiprate, 250 milligrams and 500 milligrams, were really very similar. So more specifically, if you'd like to go into the data, 5 out of 9 patients on 250 milligrams and 7 out of 15 on 500 milligrams reported being very satisfied with treatment. So in conclusion, the primary endpoint of Telestar, this reduction of bowel movement frequency, all these patient diaries, all these counts and averages and statistics, the patients were telling us that they were meaningful reductions to them. Effective reduction in bowel movement frequency led to improvement that patients noticed in their emotional well-being. They were talking to us about freedom, being able to improve their social and physical function. The highest level of treatment satisfaction was reported only on telotrestat etiprate and not on placebo. So, any questions?
I have a question. So for the placebo group, other than the placebo effect, what are you accounting the improvements to?
Well, some patients increased their use of short-acting octreotide during the study, so I think that's the most likely. And we have some documentation of that. However, we also allowed anything else that patients felt or physicians felt could be beneficial for the treatment of diarrhea. And some physicians told us they encouraged the patient, if you don't feel you're responding, hang in there. Take some extra Lomotil and maybe you can make it to the 12 weeks, and then telotrestat etiprate will be available to everyone. So I think physicians have told us they've encouraged some of the use of other antidiarrheals, including short-acting octreotide. So I think that's probably the most likely reason that some patients on placebo did a bit of a better job. Speaking to other investigators, they also described changes in diet, right? So some patients are trying to control their bowel movement frequency by controlling their diet. The physician mentioned it to us to warn us that some patients were doing so better that they were going back to diets that they couldn't tolerate in the past. He said, be careful because not all the value is going to be in the numbers, right? And I think that's one of the reasons why it's nice to have these patient interviews that supplement the story instead of just the numbers from the electronic diaries. So what's next is we submit the results to the Food and Drug Administration, and we'll see if the Food and Drug Administration approves telotrestat etiprate. That submission to the Food and Drug Administration should come early in 2016. It takes a few months to complete the study reports, but also we're collecting long-term safety data that the FDA wants to be in our submission. We want to make sure that we have a good number of patients treated for a full year in order to do that submission. Now, other things that we have going on, I mentioned there were 2 other studies going on. So people are still on telotrestat etiprate from Telestar. We have a study called Telecast that will be having results unblinded very, very soon, and you'll be able to see that. And that was patients with carcinoid syndrome who didn't quite have 4 bowel movements a day, but still had a good rationale for participating in a clinical trial and seeking treatment. And then we have another study called Telecast, which is after you spend a full year on Telestar, the third study is called Telepath. After you've spent a full year on Telestar or Telecast, we want you to still have access to treatment, and that's where we have some patients with almost 5 years of treatment now. So those 3 studies are continuing. Physicians are talking to us about additional clinical trials. They're excited about the potential to study telotrestat ederprit in carcinoid heart disease. And we're very interested in exploring some of those opportunities. And we're hearing a lot of good ideas, and we're committed to doing more research on telotrestat ederprit in the future. We think, based on these results, that the best dose for starting most patients would be 250 milligrams.
I meant, is it oral or is it injectable?
It's oral, and you take the 250 milligram tablet 3 times a day. So you take it with meals. And we had good compliance with that. Some patients don't like the idea of taking medication 3 times a day, but the compliance in this study was extremely high. So it worked out for patients to see that. Well, the study was all about alleviating the symptoms. So in this study, we had no formal assessment of tumor progression. It was a dilemma for us because it's a very interesting area to explore, and physicians are talking to us about this. But it's not something that we could really expect patients to be on treatment for a full year or 2 years to see if their tumors were changing when they were experiencing a lot of symptoms on placebo. So we made our decision. We had to prioritize the symptoms. We had to prioritize symptom control and just do a 12-week assessment. And we'll try to consider other opportunities to look at tumor control in the future. The rationale for evaluating this in tumor control is that serotonin has an important role in the growth of cells, right? It's a growth factor. That's one of the reasons patients have valve disease, right? Scar tissue is growing because of the serotonin on their valves. That's the concept behind carcinoid heart disease. The somatostatin analogs, they control and suppress the release of hormones, and they've been shown to offer tumor control to patients. So it could be that telotrestat ederprit has an opportunity too. We have to find the right setting to test that and consider our clinical trial opportunities for the future. Some patients will wait. And if we submit in the first part of 2016, telotrestat ederprit could potentially be approved at the end of 2016 and available on the market. However, we are committed to provide access to telotrestat ederprit to patients who have a very clear need and have a strong rationale for benefit from treatment. And so on the Lexicon Pharmaceuticals website, there's a section called About Us. If you go to About Us, there's a drop-down window that's about policies, and we have a policy about compassionate use. The way compassionate use will work at Lexicon for telotrestat ederprit is through the physician. The physician contacts Lexicon, and we support the physicians applying to the FDA. The physician applies to the FDA for compassionate use. So we can work with physicians through that process and try to help them with cases that are clearly serious and that have a strong rationale to benefit from treatment.
Just a follow-up to Jean's question, are there any physicians you're already working with who are submitting compassionate care requests?
Yes, there's a physician at Memorial Sloan Kettering who's submitted a compassionate use request. And then there are others that have applied from a variety of places. And the ones who have applied they know physicians that are in the network that recruited for Telestar. And so I think that's one of the best places to speak to someone like Ed Wolin has experience with telotrestat ederprit, Pam Kuntz. This network of sites that participate in the Telestar study. I think these physicians have good experience. They can help identify if this is the right treatment and work with other physicians. We've already seen that in a couple of cases in terms of guiding them. Is this a good idea for compassionate use or not? Well, we've seen a lot of patients, actually. When you go to a place like NANETS, North American Neuroendocrine Tumor Society, it's a scientific meeting. It's a patient advocacy meeting. I mean, NANETS is a patient advocacy group. So when we were at NANETS, I spoke to a lot of patients attending and wanting to see the results. And I was impressed by patients knowing their 5-HIA and concerned about the long-term impact of 5-HIA on their health. So I think that is an area that's of interest, and one of the areas we're most interested in for conducting additional research. I went to a very good patient advocacy group meeting in Philadelphia recently, where there was a patient who showed 8 years of data of his experience with Waldenstrom macroglobulinemia. And one of the things he said is that, he said, because of this day and age with internet and iPhones and all these apps, he said, patients, especially those of us who have rare conditions, we're tracking everything that we do. And we're tracking all our measurements. And I think that's something that is going to be a reality of the future. Yeah.
There's a new net app that tracks not only your bowel movements or whatever data you want to put into it, but it's also tracking mood, which addresses some of the things
Yeah.
you have in your study about depression or fatigue. And you can add all your medications to it. It's pretty broad. So that might be something for everyone to look at, the Net Health app. Any other questions? Yes?
How close is your research to submission to the FDA?
We hope to submit in the first part of 2016. So hopefully, I guess we're already in November, so somewhere maybe in 5 to 6 months as a ballpark. So hopefully that'll be soon, and we'll see how long it takes for the FDA. Depending on how the FDA handles this submission, it could take between 9 months to a year. And we'll have to see if they're satisfied that they have all the information that they need.
Ongoing, do you recommend that this is taken along with Sandostatin and octreotide together, or can you eventually phase out?
Octreotide or lanreotide. You know, the way we approached this whole program was really about an addition to the standard of care, not a replacement for the standard of care. And that was a very careful decision because we felt that physicians were really interested in continuing octreotide and lanreotide for purposes of long-term tumor control. So we're interested in research on whether we could add to that, but we haven't really embarked on any to try to replace that. Right? Yes?
Sorry, I came a little late. But it might be interesting, you might have presented this a little bit earlier, but some of the health consequences of elevated 5-HIA in serum, and whether or not you see any suggestion in your study about survival benefits or other types of benefits that were not listed here.
Yes, so our study was too short to really come up with a statistically significant difference in survival. We're fortunate there were very few deaths. There were more deaths on placebo than on telotrestat etoprate. But that's not something that where we had enough power to kind of come up with any sort of robust conclusion. We see the reductions in 5-HIA, and we see the community very interested in exploring them further. And so we'll be happy to support clinical trials.
In the clinic is cognitive function. Were you able to measure that in your study?
We did not measure it in a formal way.
Because that seems to be one of the issues that patients have when they have really elevated 5-HIA. It really contributes to their decreased quality of life. Because people are usually very high functioning, they never forget anything, you know, and they start to forget things, and it's very difficult.
In the patient interviews, we saw people talking about cognitive function. And I think there were some reports of improvement in cognitive function. We haven't looked to see if that was placebo or telotrestat etoprate. The cognitive function is an interesting area because there are two things that could be contributing to it. One is diarrhea with dehydration, you know, problems with electrolytes, problems with poor nutrition. I mean, we saw patients with really very poor nutritional status. We saw, for example, some patients very low protein because their gastrointestinal function was so poor. And then there's this other side that serotonin has a precursor, tryptophan. And if the tumor is consuming all the tryptophan, well then there's a hypothesis that that could affect cognitive function, that the brain can't make its own serotonin. It can't work independently. The tumor's kind of taken over and being the serotonin factory for the body. Yeah.
Just more of a logistical question. When people are having different scans, they have to avoid certain foods or the GA68 scan try to have their somatostatin analog shot as far away from the scan date. Is there anything related to being on this medication where they want to abstain for 30 days, or does it have any effect on scans?
Not that we know of. That's something that we should speak to physicians about. The main thing we've spoken to them about in terms of potential complications is, should you continue telotrestat etiprate through anti-tumor therapies like PRRT? And we're gaining experience on that. Long-term patients are going to surgery, and they're having chemoembolization, and they're having radiation therapy and other procedures. And just over time, in general, a lot of physicians have just kept the telotrestat etiprate on throughout. But we're going to look at that a lot more closely, and I think that'll be an important follow-up publication, the experience and safety of using telotrestat etiprate as some of these other things happen to patients down the road. Yeah.
There's no more questions. Well, thank you so much, Pablo.
Thank you very much.
All the way from the East Coast.